Today, I'm going to be talking primarily about the organization theory for implementation science framework, but I'm going to be putting it in the context of a lot of other work that I've been doing recently, and some work extending back for almost a decade now. But before I begin, I'd like to do a couple of things. And the first thing is to acknowledge the many people who have worked on this project, many of whom may not be on this slide specifically. I may have omitted accidentally, but this is a 6-year long project. And it is involved many people in many different contexts and over the history of this project. A special thanks to Jennifer Lehman, who conceived of this idea along with me and got this project integrated with the Cancer Prevention and Control Research Network, which is funded by the National Cancer Institute and the Center for Disease Control and Prevention in the US. We became a work group in the Cancer Prevention and Control Research Network. And the benefits of being part of that network are that this very conceptual work has been grounded in practice and research that is being conducted by engaging key partners in health and allied health spaces. So really grateful to all of the people who have contributed to this work, including Linda Coe of the University of Washington, who is the co-lead of the OTIS work group. I also want to acknowledge that I am speaking to you today from North Carolina, and my institution, Wake Forest School of Medicine, is located in Winston-Salem, North Carolina, and located on the ancestral lands of the Tutelo, Occaneechi, and the Kiawe nations. As my institution grows to encompass atrium health, in North Carolina, we also have locations located on the ancestral lands of the Sapani, Catawba, Sara, and Sissipaha nations, including many others. So wanted to acknowledge that. And so now I'd like to orient you to the motivation for a lot of this work, which really is rooted in my empirical work. So this may sound like a tangent from discussing the organization theory for implementation science framework, but I promise you that I will circle back around. But I think it's important to tell you, give you an intuition for why organization theories are so important for understanding implementation. So many years ago, when I was embarking on my postdoctoral appointment, I came in as kind of this fresh-eyed, newly trained implementation scientist and was looking for an implementation problem to study, being pretty agnostic to any particular content area, and was linked up with somebody named Deb Mayer, who was a professor of nursing, is now retired, and for many years was the director of the Office of Cancer Survivorship at the National Cancer Institute in the US. And the issue of the day was something called survivorship care plans. And many of you may be familiar with what a cancer survivorship care plan is. It summarizes diagnosis, treatment, and follow-up care plans for cancer survivors. And at the time, in the US, and I understand in many other places, including Canada, there was a big push to get survivorship care plans implemented as standard practice. And the rationale for survivorship care plans was that cancer survivors were lost in transition. The Institute of Medicine had this report called Lost in Transition about how cancer survivors, once they complete cancer treatment, go into this no man's land of oftentimes being cared for too many providers unnecessarily, driving up the cost of cancer treatment and chronic care management and health maintenance services. And then in many cases, perhaps more disturbingly, not receiving care at all from any providers. After going in, head first to studying the implementation of survivorship care plans, I took a step back and recognized that um, the implementation of survivorship care plans was really beside the point. The point was that cancer survivors weren't getting the care that they needed. So I shifted from trying to think about this problem of transitioning cancer of implementing survivorship care plans into why cancer survivors weren't getting the care that they needed. So in the context of my postdoctoral research, I used intervention mapping to develop an intervention designed to facilitate cancer survivors' transition from oncology to primary care. And I pilot tested it with an individual oncologist, medical oncologist at UNC, and worked out some kinks. And then once I moved to Wake Forest University School of Medicine, then piloted it in a small cancer program comprised of 5 medical oncologists. And again, started to figure out, how is this going to work in practice? And this is a pretty typical pilot experience from what I have experienced as a researcher, where it was very much a mother may I situation, where I was going in as a researcher with my team and, was able to make a connection with a nurse navigator who was willing to help me out and give me entree to the clinic and to the providers to understand how we could get this intervention implemented there for the purposes of beginning to understand its effectiveness. But this was not a priority for them. They were doing me a favor. They were participating in research because they're part of a research institution and because I was able to curry favor with them. But it became very clear to me that this was exactly the sort of work that I didn't want to be doing. I didn't want to be doing work that wasn't of interest to the people who I was asking to engage in this research, who had far bigger fish to fry than participating in a study. Now, to be clear, they were very interested in addressing the problem of oncologist overwhelm, a lack of access to appointments for new cancer survivors, newly diagnosed cancer patients. This is something their feet were being held to the fire about. They needed to get new patients in more quickly, and the length of time it was taking to get newly diagnosed patients into the door was increasing at a rate that they weren't able to control. So they were interested in the topic, but my specific intervention wasn't of as much interest to them. So I decided to shift gears, and instead of studying my intervention, I just wanted to study the contexts and try to understand what was important to them. And so it was really, I was very fortunate to get an email from the head of the service line, the oncology service line, reaching out to me saying that they were having trouble getting medical oncologists to refer successfully treated survivors to their survivorship clinic, which was staffed by approximately 3 advanced practice providers. They simply couldn't get medical oncologists to send patients there. And so I was brought in to help, and this presented a really perfect opportunity for me to start getting nosy about what their priorities were and what the issues that they believed to be the problems were. So I've been talking for a while. I'm going to pause and just ask anybody to speak up. I realize this isn't the kind of the meat of things, but don't want anybody to be too far afield. Okay, well, feel free to.
Question or comment, please feel free to just use the hand raise feature or put it in the chat, and I'm happy to moderate that.
Great. And in the meantime, I'll shift to talking about what happened once I got into this breast clinic at the main campus of Wake Forest. So I went in with a very familiar framework, the Consolidated Framework for Implementation Research. And I've been in implementation science for long enough that I feel pretty adept at using this as a general framework. And as I've been doing increasingly, and many other people have, I've discovered, is adding the theoretical domains framework. I realize what I have on here is the behavior change wheel, not the theoretical domains framework, but this has a lovely graphic that the theoretical domains framework does not. And as many of you know, the theoretical domains framework is comprised of 33 psychological theories synthesized into 14 domains. And I use it for a couple of reasons. One reason is that as Laura Damschroeder, who was the lead author of the CFR, has talked about, it really kind of expands the individual characteristics domain of the CFR and adds a whole lot of nuance that the CFR simply doesn't have. And I'll leave aside the acknowledgement that, of course, the theoretical domains framework does include some domains that go beyond individual characteristics, but let's set that aside for now. So I'm kind of going in with this in mind into this breast clinic. And because I've been working on the OTIS project for so long, I've been using this as an opportunity to, in the way that the theoretical domains framework really adds a lot of nuance to the individual characteristics domain. The OTIS does that in many respects for the CFR's outer setting and some of its inner setting domains. So don't worry about the domains here that are listed. I promise I'll go into detail about what those are. But I raise this to tell you that this is the kind of orientation that I'm going in with, that we need much more nuanced understanding of these aspects of what's happening in any given context than the CFR can provide. So the CFR kind of gives us this broad understanding of what's influencing implementation. And the way I think about the CFR now is that it's kind of like a mobile onto which you can hang theoretical frameworks. And the CFR it's a conceptual framework. It's not a theoretical framework. It has some theory embedded in it, but it also has a lot of empirical findings and some thinking from experts in the field. The difference between the CFR and frameworks like the theoretical domains framework is that the theoretical domains framework, and as the OTIS, as I'll talk about, are based in theory. They are comprised entirely of theory. And that is important because theory allows us to predict relationships, and they identify mechanisms underlying the relationship between included constructs and implementation. And identifying mechanisms is really important for identifying implementation strategies that can address those determinants. So that was a lot of jargon, but I'll go through. So I won't go too far into what I found in this kind of contextual inquiry into the breast clinic. But I think what I found, not only in this study, but in many other studies into understanding this particular problem of transitioning breast cancer survivors, is that it is a multi-level problem. And many of the things that you might expect to be driving the really sticky lack of transitions that happen are present here. So, you know, many of the very common things that I hear, particularly if I'm talking to a survivor or a medical oncologist, is, you know, a medical oncologist doesn't just want to see people who are undergoing active treatment. They want to see the people who they've developed long-standing relationships with and who are success stories. And that for the provider's mental health, it's very important to see those survivors. Other issues that I often hear are lack of trust in primary care providers, that they will provide the standard of care that is required for cancer survivors who, of course, have late and long-term effects associated with cancer treatment. But in my investigations, there are so many things that don't come up when I'm talking to lay people about this problem, and really are derived from deep contextual inquiry using theoretical frameworks and the overarching conceptual framework, CFR. So some of those have to do with things like patients coming from all over. And I know that this is an issue for Canada as well. In North Carolina, that is also very rural. Patients come to hubs from all over, and things like limited embeddedness of patients with their local primary care providers. Another issue that has come up recently is the high cost of transactions between nurse navigators and all of the different resources that survivors require to thrive. And so the requirement of a nurse navigator, for example, to refer a patient and ensure that that referral was taken up is simply too high for them to engage in. There are many other things that I could talk about, but I won't bore you with those nitty-gritty details. So I care much more about why those things are influencing implementation than what those things are. And the reason I care so much more about why those things contribute to the problem of these poor or non-existent transitions is because once we know why and how those things are influencing implementation, again, we can intervene on them with strategies that are specifically designed to influence implementation. And I'm sure I'm speaking to the choir here when I say I'm sick of seeing implementation strategies that are so idiosyncratically or conveniently selected. I don't want to see any more education if knowledge is not the problem. I don't want to see any more external facilitation if the problem really relates to things like a lack of resources that an external facilitator can't help with. This is why I feel so passionate about theory to facilitate implementation. So let's talk about a little bit about theories. Theories are different from conceptual frameworks or models in that they give us the power to predict, and they propose specific relationships among included constructs, which tell us what mechanisms are. Before I talk about theory, I just want to say there's an expanding literature on implementation mechanisms. And some of that literature does nod to theory, but I'm worried sometimes when I read that literature that oftentimes they're building logic models from scratch. And I worry about the idiosyncratic nature of that because there's nothing new under the sun. And we can stand on the shoulders of giants, which is what we're supposed to do as scientists. We're supposed to take knowledge that has already been derived from years of research and inquiry and thought. And theory is the mechanism that we translate knowledge through. So you can go ahead and read all the literature you want in a particular content area, but to understand thinking about the mechanisms underlying these persistent problems, theories are the place to go. So a good example of this is the theory of innovation implementation by Klein and Sora from 1996, developed for the field of manufacturing. And Brian Weiner in the early aughts, I think, brought it into implementation science and healthcare. And it proposes what's here on the left. and proposes these relationships, many of which I imagine many of you will be quite familiar with. And then because Brian Weiner brought it into implementation science, I became familiar with it. And I and many other people like Christian Helfrich have begun to kind of tinker with it and think about the way different variables might be relevant here. So in my work, I've thought a lot about, well, what about leadership, which I guess is not even represented in this graphic representation on the left, but Klein and Sora proposed that leadership and management in particular was a determinant of implementation. Well, that's great, but it didn't talk about what levels of management. And in some of my research, I've identified how middle managers, people like practice managers, nurse managers are really integral to translating kind of top leaders' ideas about what should be happening into practice. Okay, so this is why I'm so passionate about theory. I was trained in organization theory, in part by Brian Weiner. When I took over teaching the organization theory course in my department at UNC, Brian Weiner encouraged me to look at the potential role of organization theory for implementation. And so my students and I began to think about that, and we wrote a paper, I think maybe in 2017, I think. And since then, we've really been elaborating on this. So what are organization theories? They provide explanations for the complex interactions within and between organizations and their contexts. They help explain and predict implementation outcomes like adoption, reach, sustainment is a big one for me. And I could talk for ages, and I won't, about why I think organization theory is so important for sustainment in particular, but I'll restrain myself. They can start to help us think about how things like policies, and when I say policies for me, in my work increasingly, that's policies from organizations like the Commission on Cancer in the United States, which sets standards for the accreditation of cancer programs. Thinking about how those things really start to influence implementation and how they can be modified to facilitate implementation instead of what we see a lot, which is kind of adhering to standards as they're written, but not really the spirit of the standard. And unfortunately, just telling people that organization theories are helpful is not really all that useful, believe it or not. So they've remained pretty inaccessible. And I certainly was not the first to advocate for the use of organization theories in implementation science. People like Becky Yano at UCLA many years ago advocated for the use of organization theory. So now I'm really going to dig into the methods of what we've done here. Our objective in this particular effort, and there are multiple stages that I'm going to go through, was to develop a framework to make organization theories really accessible to implementation scientists who we don't, of course, expect to be trained in organization science or organization theory specifically, and may not have deep understanding of organization theory constructs. So I, like most people, don't know the nitty-gritty of all of the individual constructs within the theoretical domains framework, but I have a pretty general sense of the domains to help me organize my thinking about what might be happening with an individual. And so we wanted to do that for organizations in this effort. Okay, so here's an overview of how we've gotten to this point. I mentioned that paper that my students and several collaborators and I wrote in implementation science, just kind of proposing in a conceptual way why organization theories might be relevant for dissemination and implementation research. And then after that, we compiled organization theories that were represented in that course that I taught to PhD students in the Department of Health Policy and Management at the University of North Carolina at Chapel Hill. And we used that survey of experts in organization theory to figure out, are we missing any organization theories? Turns out we were. And what are the journal papers that we might use to learn about these theories from? So we took the results of those surveys and we went through a consensus building process. This is all many years ago now, to figure out what actually qualified as a theory. So that involves prediction, that involves causal relationships among included constructs, and falsifiability, which is really important, and the ability to derive hypotheses in a way that is not necessarily possible with a conceptual framework, for example. And then we went through the process with the Cancer Prevention and Control Research Work Group. A few of us, 2 abstractors per theory, went through those journal papers from, that describe the theories originally, the 9 that we ultimately included, and any applications of that theory that in implementation. I think it's important for me to go back and just mention one of the other criteria for inclusion as a theory was not simply being an organization theory, but being an organization theory with relevance to implementation. Certainly there are organization theories that are not relevant to implementation. And so 2 abstractors per theory went through and abstracted constructs from the theory, propositions from the theory, the general tenets of the theory, and started to talk about potential applications to implementation. And you can actually find those abstraction forms on the CPCRN website. So I think it's cpcrn.org, and there's a resources tab in there that has all of these PDFs of the abstraction forms that we got, that we developed after reconciling discrepancies. And sorry, you can't see, but here's my cat. She's decided to make, okay, there we go. So we have 70 constructs to distill into something that is understandable and manageable to start to think about developing an interview guide with. We don't want to be doing interviews probing on 70 constructs. That's very difficult to do, particularly with busy healthcare professionals. So how can we start to distill this into domains? And that's where we are today, talking about that process. These are the constructs from the included theories. And those theories are complexity theory, contingency theory, institutional theory, transaction cost economics, the network perspective, organizational learning, resource dependency, population ecology, and socio-technical theory. Together there are 70 constructs. So we began and originally proposed concept mapping. And so concept mapping is a process that I've used before and many other scholars in implementation have used, and I'm sure in many other fields. And I've been very successful with concept mapping in the past with highly interpretable findings. As I'll talk about in a little bit more detail in just a moment, that was not the case for this project. But at any rate, concept mapping in Global Max, which is the software that we used, is an online virtual card sorting process. So what we asked 25 scholars to do was to sort 70 constructs into piles that kind of represented similar concepts, similar ideas. And then the software uses multidimensional scaling and hierarchical cluster analysis to create these maps like you see in the middle of the screen, where the numbers represent constructs and the shapes represent domains. You can redraw the lines across these constructs, these little numbers, to create different shapes and kind of shift things around. So in previous projects, you know, there was maybe a stray number that we would incorporate. For example, the teal triangle on the right might be absorbed all the way into the purple parallelogram at the top right, to create a new domain, so reducing the number of domains by one. What we did, what we set out to do was at the CPCRN annual conference in Denver, we sat together in a hybrid format. So many of us were in person and several of us were online to go through the many different concept maps that Global Max produced. And we went through trying to make sense of them and identified some cluster maps that made some sense. And then really what we ended up doing was having a series of meetings after that first one, just to kind of sort through and try to make sense of what were, quite frankly, uninterpretable concept maps. I'm not sure exactly why they were so uninterpretable in this case. I don't know if it was the number of constructs. I don't know if it was poor instructions about kind of what the clusters would mean, what those virtual piles would mean. It's really hard to know. But by engaging people in this kind of consensus building process, we were able to make sense of the clusters and arrive at the 6 domains. I can't remember exactly how many meetings there were, but at least 6. We meet monthly, if not more often, and via email as well, to reach consensus on what ultimately became OTIS. And this is it. There are 6 domains in OTIS. There are organizational characteristics, governance and operations, characteristics of a population of organizations, tasks and processes, knowledge and learning, and interorganizational relationships. And before I go into too much depth, and I'll give you fair warning that after I go through each of these individually, I'm kind of quick discussion points. I'm finished, so I'm happy to talk about it in depth. But I do want to preface all of this by saying we originally intended for OTIS to be a work in progress indefinitely. And so if we need to add theories, we can do that. It will be a process. I will be hopefully presenting OTIS at the Organization Theory and Healthcare Conference at Stanford in May, in a workshop where I'll get feedback from organization scientists. So this is not set in stone. So without further ado, I'll talk about organizational characteristics. Oh, actually, before I do that, I just want to pause if there are any questions about the methods before I launch in. All right, so you can kind of think about organizational characteristics as the demographics of the organization. I hate to anthropomorphize organizations because as somebody with training in organizational sociology, I do not believe that organizations are simply aggregations of individuals. I think they're emergent properties. But if you want to think of an organization as having an identity, this is the domain that describes them. It's how old they are. It talks about their kind of general orientation as I have a friend who talks about the whole world being split up into fast people and slow people. I'm a fast person. I do everything fast. My son is a slow person, does everything very slowly. Any history of failures and recoveries from those failures that leave scars on the organization, how professionalized its workforce is, how big or small it is, and how it's organized in terms of kind of the organizational chart. The second domain is governance and operations, and this is really how the organization is set up to get work done. I think it's really important for me to convey that this isn't just kind of the objective characteristics of the systems that are set up to get the work done, but it has just as much to do with the implicit rules that we all carry around in our head and that are encoded in the way we set up meetings, how we talk to each other during meetings, who is designated as the person to do the next step in any given process. All of that really has to do with governance and operations as well. Tasks and processes are the work. They are the things that are getting done, and this has to do with things like how frequently a particular transaction happens among people inside the organization and outside the organization, and what those relationships are like within or across institutions, how dependent an organization is. When I talk to the program officer for, a grant, I am totally dependent upon that institution for the resources I need to do the work that I do, and in a way that is not the case with collaborators at a different university, for example. And the cost of transactions is another thing we think about. The cost of transacting in 1950 to do health services research is really different than it is now. So all those sorts of things and more go into this domain. Knowledge and learning is about how we translate information in organizations into knowledge. So this isn't just about kind of, a top manager scans the environment to figure out what's happening in the environment to inform what happens in the organization. This is about kind of what is considered knowledge in the organization. This is increasingly important in the era of learning health systems. Information is not knowledge. And who creates knowledge and the systems through which we generate knowledge is hugely political, and that goes into this as well. So populations of organizations are defined by the question. So, there's Caramel's tail. So for any given research question, the population of organizations may be different. So this may be a group of hospitals that competes for market share in a given geographic area. This could be one hospital and the institutions from which it gains revenue. It could be the communities in which it operates. So you can see how a population is not a defined thing. So if you scale out, the first domain was organizational characteristics. And I didn't like to anthropomorphize the organization. This is one level up from an organization. So you can kind of think about this as, a community of organizations and what characterizes a particular community. How much do those organizations look like each other? How constrained is that population in terms of what it can do, when it can do it? How uncertain are the resources that a population has to work with? Like, if we're talking about a population of hospitals, how much does the patient population flux? Things like that. And then the final domain is interorganizational relationships. So this has to do with those ties among organizations within a population. And this, again, has to do with kind of all sorts of dimensions. I don't want to say it's all political. It's certainly not, but politics has to do with it. Who is central in those relationships? How dependent are those organizations upon one another? How much power is wielded in those relationships among organizations? What linkages exist, and perhaps more importantly, what linkages don't exist among those organizations? So if this is the Reader's Digest version, we synthesized 70 constructs from 9 organizations into 6 domains. And so that's great from my point of view, because we can start to think in more simple, I don't want to say simple because it's not simple, but ways about these organizational and population influences on implementation. So my dream is that we won't just talk about organizational factors as this monolith. We'll think about it in more nuanced ways, and that we can start to identify the mechanisms that can point towards strategies to facilitate implementation. And so I just want to close my conversation by saying a couple of things. One is that this has been hugely helpful to me in my empirical research, and I have identified strategies that I think are going to be far higher impact than if I had not done this deep contextual inquiry. So the leaders of the breast clinic that I've been working with are all in on solutions like creating decreasing the number of organizations that they contract with, so that there's just more of a relationship between the breast clinic and the external organizations that they're referring patients to, so that they can start to develop ways of working that are more efficient than spread out across many different organizations. I'll give as another example, we're really integrating not just across clinical folks, but also operational people, and also researchers such as myself, so that we're governing together in a way that kind of creates a culture of cross-fertilization. And the last thing before we start to talk is this very important point. So Max Weber is kind of a grandfather of sociology, and wrote The Iron Cage, which is about organizations. And it turns out, I think the Iron Cage was a mistranslation from German. It's not that kind of organizations box us in and make us do things that we wouldn't otherwise do, but also organizations can create structures that can facilitate equity in a way that we may not be inclined to because of unconscious bias. So I want to kind of make an analogy here that OTIS, like I've suggested before, is something that should be constantly critiqued through application. It is not correct. These are ideas that have been carried forward for many, many years up to 70 years in some cases. And so it's incredibly important that we critique them, because there is no doubt that they carry forward white supremacist and misogynist ideas, and we need to work rigorously and carefully to shake those pieces off of the organization theories that are included in the framework. So I'll stop there, and I'll stop sharing my slides so that maybe people can pop on if they'd like. And yeah, I'll turn it over to Tina.
Fantastic. Thank you so much for that incredible talk. I'm going to try to leave my video on and see if we start freezing. So I'll just invite people to either raise their hand or put a question in the chat. We have about 10 minutes before we end with a little bit more housekeeping. So we already have a question. I'll just read this out. So for this, really interesting. I'm interested in the notion of emergent properties of organizations beyond the sum of the individuals within them. As a psychologist, I tend to think of implementation as boiling down to individuals making individual decisions and doing individual behaviors. Does the OTIS framework provide guidance on the source of these emergent properties specifically? And do you see it as most tied to the community of organizations / interorganizational domains?
I love that question. That's great. And Tina, you froze at the end, but I saw that was the end of the question. Thank you, Jamie, for the question. And I have gone head to head with psychologists about this really fundamental question about whether or not there are emergent properties of groups or teams or organizations. And I'm firmly in the yes camp. So whether or not OTIS provides guidance on this, yes, there are pieces of this throughout. So you can see, for example, things like, well, I talked about knowledge creation. Knowledge is persistent in organizations and encoded in documentation, like policies and procedures that transcend individuals and are passed along for years and years and create a culture and a climate. There are other pieces like the network perspective, for example, offers insight into how these interorganizational relationships and relationships within organizations persist over time. And it's kind of like a well-trodden path. It doesn't necessarily need an individual on that path at all times to continue to exist. Another example I'll give is about from institutional theory, which proposes this notion of isomorphism, which is organizations tend to look alike over time. And that has to do with many different influences, but one is the kind of extra organizational influences like federal policy or professional organizations that set the tone. And whether or not I see it tied to the community of organizations or the interorganizational domains, it actually, I would argue, is intra-organizational as well. So we see evidence of, right, of course, cultures within organizations and policies and procedures and stuff that completely transcend an individual. And there is some empirical evidence of this as well. Again, Brian Weiner, Sarah Jacobs, and Alicia Bunger wrote a paper about the inability to necessarily aggregate across individual responses about individual perspectives of implementation climate, that really it is an organization level phenomenon.
Fantastic. Thanks so much. There's another comment in the chat from Joanne. Joanne is wondering whether any of the theories addressed incentivizing. So middle managers are often rewarded for managing the status quo and change is difficult for them. So is that something that is considered in the OTIS?
That's a great question. And I have not thought about what the implications of OTIS are for middle managers. Believe it or not, that's a great idea. We should explore that. Joanne, hit me up. But I just off the cuff, I'll talk about, again, I guess I'm just thinking a lot about knowledge creation, but in some of my previous research, I have talked about how middle managers have been instrumental in synthesizing knowledge. So I wonder if there's something in there, and advocating for including middle managers in strategy discussions, because if they're part of strategy discussions, that orientation to change may be they may be more amenable.
So another question in the chat, this one's from Noah Ivers. So Noah's asking, where in the OTIS does the culture of risk aversion fit?
The culture of risk aversion. I mean, I think it can be found in many different places, but the thing that jumps to mind is within institutional theory, this idea of wanting to be like other organizations, because if other people are doing it, other organizations are doing it, it can't be that bad, or at least kind of diffusing risk across a population of organizations. Like if everybody is doing the wrong thing, it'll be okay for, the index organization. I'd have to think about other examples that don't necessarily jump to mind. And I see Rossman put in a question about de-implementation or decreasing use. I have not seen an application of that yet, but I think there's a lot to explore with respect to kind of which implementation outcomes OTIS addresses. I talked about, to me, and I might get myself into some hot water by saying this, but that de-implementation is kind of the antithesis of sustainment, right? We're trying to either get people to do things for a long time or to get them to stop doing it altogether. And as I alluded to earlier, I think there's particular application of OTIS for sustainment, because to be sustained over a long period of time, it has to, a practice has to go beyond individuals. And that's where organizational systems come in. And so to me, de-implementation has to do with addressing systems as well.
Fantastic. And if I can squeeze maybe one more question in before we do wrap up, I wonder if just going forward, you could give us some suggestions on tools people could use to begin using OTIS. And specifically, I love the slide that you showed at the end there with that connected to the strategies. And are there any kind of suggestions of once we've done an analysis using OTIS, how we then move to figuring out which strategies we should use to address any barriers?
Yeah. So Kristen Morrill of the University of New Mexico is putting in a proposal right now to develop an interview guide and codebook based on OTIS. So those are tools that hopefully will be available in not too long, in the next couple of years. And I'm happy to share ideas offline about kind of a preliminary way of thinking about it. And in terms of translating to strategies, I'm not too precious about this. I think it's just a question of thinking critically, and it will have to be routinized in some way. But I remember reaching out to people like Justin Perceau when I was applying the theoretical domains framework, and as a health psychologist, he was able to help me kind of link the factors that we identified in our analysis to to strategies based on psychological theories. So I think that's probably the way it would need to be done for now, but it would be great to develop something like the behavior change wheel. Oh my gosh, the organization change wheel. How great would that be?